So where can a person be involuntarily admitted? Under Section 22, any person can take a person to a designated mental health facility or psychiatric unit. That sounds a bit confusing, but what it's saying is that you and I are allowed to take a person to a designated mental health facility or psychiatric unit and ask a doctor to see them admitted, even if they don't want to be admitted. Locally, as we said, Abbotsford Hospital and Ridge Meadows Hospital are designated facilities. Mission Memorial Hospital is not, and so non-designated hospitals such as Mission do have a legal obligation to transfer a person to a designated unit and then provide that care as they're in transit. That sounds fantastic, but there are some significant limitations. First of all, people often go to Mission Memorial Hospital because they have transportational issues and they cannot get to Abbotsford. Perhaps it's difficult for their family or other supports to get to Abbotsford, and that's critical for many people because they just don't want to go through this process without having a support person there. There's also a cost associated. Even if the person somehow has their costs not included in getting to the facility, they often have the unpredictability about how they're going to get back. So they may be lucky in having somebody from their family take them there. What you'll often hear people from Mission say is, take the individual directly to Abbotsford. There will be less bureaucracy and more chance that they'll interact with somebody who is a mental health clinician. But we often are resistant to do that. We feel as though we're entitled to go to our local hospital. We feel as though it's the only convenient option. And the truth of the matter is, the reason that Mission Memorial Hospital is not a designated facility isn't because of some kind of political decision. It's really a clinical decision. It's really about the fact that in order to have mental health professionals working out of a facility, they need to have sort of a critical mass of patients that come in every day to keep them busy. Mission Memorial Hospital is not able to do that, whereas having a regionalized approach, and that's what Abbotsford Regional Hospital is all about, allows for the centralization of services so that now all of that knowledge, all of the infrastructure can be in one location where people can have their resources in an intensive way instead of having them watered down over 2 or 3 hospitals. I have been through the same exact mental process where I've thought to myself, I'm going to Mission Hospital first, and that's my local hospital. That's a sentimental perspective that I totally understand. But at the end of the day, going there doesn't mean that that's the best place to get mental health assistance. It's not a bad idea to go there if your situation is extremely urgent or if a person has a medical need as well. But if you have the ability to help a person go directly to their local designated hospital, it's probably going to be less bureaucratic, faster, and less frustrating for everybody involved. It is almost always better for a person to go and be admitted under Section 22 than it is to go to jail. And I say almost just because there are some people who are so traumatized by mental health facilities. But generally speaking, jail is a place where A, we cannot provide any follow-up, B, there's no real ability to treat or medicate a person in that crisis, and C, if something happens that is a medical emergency, the person, for example, is going through withdrawal, which can be a physically dangerous situation, we are too far away from medical intervention. So jail is not really a suitable alternative to a person being admitted for a mental health need. By the way, as we've said, a person doesn't only get taken necessarily to a hospital. If they seem that they would be more willing to go to their own physician, or if you think that their own physician is more likely to be able to convince them to pursue voluntary treatment, then that is highly recommended. What are the criteria a physician uses to admit somebody even against their own will under Section 22? Well, there are a number of them, and they must all be met. In fact, there are 4 specifically. So the person first must have symptoms of a treatable and seriously impairing mental disorder. And this is where the rubber hits the road for many of these admissions, because a doctor may say, that individual has a drug and alcohol problem. I'm working in a facility that does not have the capacity or knowledge to treat an individual for a drug and alcohol problem, ergo I'm not going to admit them. I think it's really important for us to understand that the doctor is not necessarily required to admit a person with the expectation that they would complete all of the stages of that individual's care. They may be admitting them just long enough to stabilize or allow a social worker to make a referral to a community resource. Now, I don't want to be a Pollyanna here again, but it's important for us to understand, of course, that there sometimes are limitations on those community facilities. So we know that there can be wait lists. There may not be space. But at the very least, giving that person an evening or two of respite can allow family or social workers to sometimes deliver on some creative solutions, some informal support that can make all the difference in a person's life. So the criteria does not say that the physician must do all of the treatment or that that person must stay in that same facility on an ongoing basis. It simply says that they can be admitted. That physician can choose to discharge that individual, again, 6 hours, 12 hours, 24 hours down the road if a suitable referral is possible. The other criteria is the person requires psychiatric treatment in and through a designated facility. So again, that's in and through. It's not necessarily that the person only is going to come to that psychiatric facility. They could be referred by coming through that facility. Number 3, they require care, supervision, and control in a designated facility. Again, that doesn't need to be for months at a time. It might just be that their initial care is there, and then they can be referred on to further care, like, for example, the Crest facility in Abbotsford. And they must not be able to suitably be admitted as a voluntary patient. So you're coming in the door with a family member or a consumer as a first responder, and you're hoping the doctor will Section 22 this individual, and maybe somewhat surprised or even frustrated that the doctor is seeming to take a more patient approach. They may feel as though, for example, you may feel as though they haven't taken your word for it when you said that that individual had presented dangerous symptoms or symptoms that were apparently a mental health disorder. Well, the doctor is not distrusting you. The doctor is, however, trying to see whether or not there's a way to admit this person voluntarily. And as we said in the last video, that's going to be significantly better for the individual in terms of their health care, in terms of their treatment plan, but also is going to make it less invasive, less cumbersome to keep that individual in the facility because going through creating medical certificates is an onerous activity, and that's what a physician has to do in order to keep that person admitted. What about BC Ambulance? What do they need to think about? What are some considerations that BC Ambulance should have? Well, BC Ambulance, of course, can transport any person if they believe the person has an emergency need that's tied to any form of medical care, including psychiatric care, to a medical facility, an emergency medical facility. But what sorts of things should we think about aside from whether we have the right to do it? Well, obviously we have to think about, of course, our safety. And this transcends just the BC Ambulance people, but everybody who might have to transport somebody to a facility. It really is important for us to make sure that we do that only when it's safe and only in a way that is safe. For example, we might need to have the police help us to escort an individual and follow behind. We also have to think about the role and effect of restraints. There are a number of different ways to restrain a person. We can tie them down, for example, to a gurney. We can help them to take medication, although BC Ambulance would normally not do that. Or we can have the person put in handcuffs or in the back seat of a police cruiser. And we need to really think about, especially if we have any sense of the history of this individual, whether or not that's likely to aggravate the situation. Because at some point, of course, those restraints have to come off the individual. And if they're hard to deal with right now when there's perhaps 2 BCAS staff, a small crowd of people, and 2 RCMP members, it's going to get that much worse when we get to when we get to an emergency facility, and now we've got a bunch of people sitting around who are sick and injured, as well as a bunch of other staff, and it's going to be a very significant issue. So one of the things we can also think about is there a way for a family member or friend to accompany? And that may not be possible in the actual ambulance, but can the person follow behind and reassure the individual that they are going to be coming along? And isn't it wonderful that in this day and age of technology, we can actually text and phone people even while we are the passenger in a car, not a driver, but the passenger in a car that's following behind and letting the individual know that we are still there. One's personal effects. We've talked about this a few slides back when we talked about frustration. One of the things we hear from mental health consumers in crisis going into places like psych wards or homeless shelters is they often are reluctant to take the care or to stay in these facilities just because they do not feel that their personal effects are allowed to come in or will be safely stored. They worry about theft or loss. And again, we may look at that and say those people don't have a heck of a lot, so what's their problem? But in fact, it's the opposite. They don't have a heck of a lot, so what little they do have, they tend to hold on to pretty closely. So showing people that you are taking good care of their personal effects will help them to stay calm and make your job easier. We really want to make sure that we are aware of what people's medications are, and make sure that they have taken their medications, if possible, as currently as they can. We may find out, for example, that an individual has access to a PRN medication that deals with psychosis or agitation, and help them to take that medication because they've already got a prescription that's active. And that may make it so that we don't have to transport that person at all. We may find that they're taking something like a sublingual Ativan, and within the next 10 to 15 minutes we'll be able to tell whether that person is able to stabilize, as well as giving some time for that individual to have other care people come and give you some information on what that individual's usual cycle is. So that's the next thing, talking to the next of kin and finding out some history about that individual and really finding out what's likely to happen. Or would we be aggravating that person by taking them, or would they be better off in our care? And how to respond to the self-reports of an individual is very important. So we always have to be aware that we need to check the accuracy of people's information, but we must also remember that to that person it is 100% accurate what they're telling us. So their perceptions are extremely vivid to them, and we have to show respect for that. We cannot, for example, actively question people's credibility, and it's very hard for people to understand this, but I can guarantee you nothing will get a person to escalate more quickly than telling them or indicating to them through your behavior that you don't believe them, even if you don't believe them. So if you have to go off and validate what a person is saying, I think it's best to do that in a way that is set aside from that individual. And sometimes it might be necessary to do that in a deferred and delayed way. And take a great look at the person's demeanor. This is probably obvious, but we want to not only hear the words, but again, denote what the person is saying to us non-verbally. And we can reflect on that as we're reflecting on what people communicate, as well as we can record that. So when we get to the emergency room later on, we can tell the physicians when we get there what sort of motor activity we saw, facial expressions we saw, the distractibility we saw, and so forth.